This conference will now be recorded.
Uh, Good afternoon. Can you hear me?
Yes, sir.
Can you see the screen?
Yes, sir.
Okay. So I will be refreshing some topics. So I want to cover some cover this anal canal anatomy and few topics. I will be completing this. So I will be going from lower GI to upper GI. I will be discussing some few important questions relating to each chapter. So today we will be discussing about anal canal anatomy, surgical anatomy. So I will be just refreshing the topic. I will not take too much time on this because already you might be knowing about this. So let's discuss about the anal anatomy, surgical anatomy. And I want to discuss about the anorectal abscess also, because anal canal anatomy is somewhat complex. So before going into the proper topics of anal canal disease or anal canal disorders, you need to know some basic anatomy. Okay, then only you will be able to understand the what actual diseases which are related to the anal canal, because anal canal anatomy is somewhat complex. Hmm. So we'll be discussing now. We'll say anal canal anatomy. See, I have told you previously also in my previous classes. Whenever a question has given, you should be writing in some orderly pattern with some side headings. So always you should skeletonize the answer. So whenever an anal canal anatomy is given, you should be able to know surgical anal, what is surgical anal canal, what is anatomical anal canal, what is the shape of the anus, what are the relations to the anal canal, anterior, posterior and lateral relations, what is the mucosa and submucosa of the anal canal, what are the surrounding muscles in relation to the anal canal, that are the sphincters. Okay, next the blood supply, lymphatic drainage, nerve supply, and the important is the spaces around the anus, spaces around the anal canal, and the importance of dentate line. So any question, if any question is given, you should be writing under side headings. Okay, like in this pattern. So surgical anal canal, you can see in the figure. So here I am placing the cursor over here. So this is the surgical anal canal. This is, it extends from the anorectal junction. This is the anorectal junction to the anal verge. This is the anal margin. This is the anorectal junction. So from the anorectal junction or the anorectal ring to the anal verge or the anal margin is the surgical anal canal. So it is 4 to 5 centimeters in length. So then what is anatomical anal canal? Anatomical anal canal is the line, is the distance between the part between the dentate line. Here you can see the curved dotted line. From the dentate line to the anal margin is the anatomical anal canal, which is measuring about 2 to 3 centimeters. So anal canal always it is in a constant close, it is not in an open position. In all individuals, in all human beings, it is in a closed position. This is due to the constant tonic contraction of the internal sphincter. Okay, so it will be an anterior posterior slit in shape when it is in closed position. Okay, so the relation here you can see the relations. Here is the anal canal, this is the anal opening. Anteriorly you can see the membranous part of the urethra and the bulb of the penis. Okay, membranous part of the urethra and bulb of the penis, which is being separated from the anal canal or the anal opening from the perineal body. This is the middle part is the perineal body. On either side is the superficial transverse perineal muscles. So the perineal body separates the anal canal from the bulb of the penis and the membranous urethra. Whereas the posterior, sorry, and in female it is related to anteriorly with the lower part of the vagina. Here also the perineal body will be separating the lower part of vagina from the anterior part of the anal canal. While coming to the posteriorly, it is related to the bony part, that is the coccyx. This coccyx is separated from the anal canal by the anococcygeal ligament. Okay. Laterally, it is related to the ischiorectal fossa. So on either side of the anal canal, you can see this is the ischiorectal fossa. Okay. So when coming to the mucosa, that is here you can see the black line. Okay, that is the mucosa of the anal canal. Here upper part is the rectum. Somewhere here near the puborectalis, here the anorectal junction. Anorectal ring is nothing but it is formed by four muscular components. One is the puborectalis, one is the conjoined longitudinal muscle, third is the external anal sphincter, and fourth is the internal anal sphincter. So these these are the four constituents of the anorectal ring. So here somewhere here is the anorectal. Below this anorectal ring is the surgical anal canal. Okay. So this mucosa, again this surgical anal canal is divided into upper half and lower half based on the dentate line. Okay. I have shown you the dentate line. Here is the dentate line. Above dentate line and below dentate line, there is very much a surgical importance and anatomical importance. You may be asked a question about importance of dentate line also in the just as a 2 marks question or a 4 marks question. Dentate line or a pectinate line, they may give you as a question, short notes or a very short notes. You must be able to write some 8 to 10 points regarding this dentate line, as this is a very important question also in the examination. So this dentate line differentiate from the upper half and the lower half of the anal canal. So if you see the epithelial lining above the dentate line, it is usually simple columnar epithelium, and it is a continuation of the columnar epithelium of the rectum. The rectum mucosa is lined by columnar epithelium. So that continuation of the columnar epithelium will be passed to the upper anal canal. Okay. So that is the epithelial lining. So what is the color of the upper half of the anal canal? The upper half of the anal canal, the submucosa, here you can see there is a rich submucosal internal venous plexus. This is called a superior hemorrhoidal plexus. Okay. Due to this, the color of the upper anal canal appears to be plum colored. Okay. Next, what are the columns of the Morgagni? See here you can see the columns of Morgagni, or in the previous picture I will show you. So this is the columns of the Morgagni. You can see vertical folds. These are the vertical folds. The mucosa of the upper anal canal will be folded itself into longitudinal folds or vertical folds. Okay, these are columns of Morgagni. So these columns, each column of Morgagni is supplied by a superior rectal artery and a superior rectal vein, which is a branch of inferior mesenteric artery and the inferior mesenteric vein. So this superior, as you know, the superior rectal artery and the superior rectal vein radical, this two components form a radical. These radicals are very much prominent in 3 o'clock, 7 o'clock, 11 o'clock. That is the when you keep the patient in the dorsal or lithotomy position and you see the anus. So if you think as a clock, if you see this anus, if you kept this is in a lithotomy position, so this will be the 3 o'clock. So this is the 7 o'clock. So this is the 11 o'clock. So this will be 3 o'clock, 7 o'clock, and 11 o'clock will be having some named radicals, that are prominent radicals. Okay, those are called as the primary hemorrhoids. So when these radicals gets enlarged, then they are called as the primary hemorrhoids or the primary piles. Okay, that is the left lateral position, right anterior, and right posterior. Okay. So this 3 o'clock, 7 o'clock, 11 o'clock, those are also called as anal cushions. Okay, anal cushions. So what are anal valves? Anal valves are nothing but, see here is, these are the anal valves. Anal valves are the concentric like folds which join the lower part of the columns of the Morgagni. See, these are the folds. Okay, those are the anal valves. What is the surgical importance of anal valves? When the patient when a human pass hard feces, what happens? These anal valves will get teared up due to shearing forces, and due to tearing up of the anal valves, there will be a longitudinal slit from the dentate line to the anal verge or anal margin. Okay, so then it will form a fissure. That is the surgical importance. So what are anal sinuses? Anal sinuses are nothing but the recesses or spaces just above the anal valves. Just above here you can see small pockets. Okay, so here anal walls and above anal walls there are small pockets or recesses. Those are called anal sinuses. In the anal sinuses there will be openings where the anal gland opens into the anal sinuses through a duct. Okay, anal sinuses through a duct. So the depression which is formed by these ducts at the opening, there will be a small depressions. Those are called as anal crypts. Those are called as anal crypts of Morgagni. Okay, excuse me. Okay, can you hear me? Hello.
Yes, sir.
Okay. So those are the anal glands and anal ducts. Okay. These anal glands are situated in the intersphincteric plane. Okay. This is the intersphincteric plane, that is between the internal sphincter, external anal sphincter. Anal glands are located in the intersphincteric plane and in the submucous space also. Okay. These anal glands through the anal ducts open into the where? Anal sinuses at the level of dentate line. Okay. Next is the dentate line or the pectinate line. I have showed you the dentate line or the pectinate line. See this curvy dotted line. Okay, the curved dotted line is the dentate line, which I will be later explaining about that. The anal papilla are nothing but the remnants of the anal membrane, which are situated just above the dentate line. Okay. So what is transitional zone or pectin? So below this dentate line, here you can see the part here. Okay, below the dentate line is the transitional zone or pectin. Okay, see this color and this color. It is dark plum colored. It is pale brown in color. So the main differences between these two is color. Number one, color is it is plum colored. Below is pale brown in color. Here the mucosa is lined by simple columnar epithelium, whereas below this dentate line it is stratified squamous epithelium. Here the mucosa is very much folded to form columns of Morgagni, whereas here the mucosa is very much stretched and it is thickly adherent to the underlying muscle through tough connective tissue. Okay, so this pectin here you can see a fair line. Okay, you can see a fair line here. Okay, that is called as white line of Hilton or anocutaneous line. Okay, This line represents the junction between the internal anal sphincter and the external anal sphincter. Here you can see the internal anal sphincter and the subcutaneous part of the external anal sphincter. So this can be palpated in the patient also. Okay, there will be a groove like thing. Okay, between the internal and external anal sphincter. Okay, and next is the anodome. Anodome is nothing but the anatomical anal canal, which also represent anodome, that is the from the dentate line to the anal verge. Okay, so what is next? Submucosa. Where is it located? Here you can see the submucosa is located. See, this is the submucosa. It is located between the mucosa and the internal anal sphincter. It constitutes the connective tissue, vascular tissue, and muscular tissue. Okay, so that is about the submucosa, and there is an important structure called mucosal suspensory ligament. This mucosal suspensory ligament is nothing but, see, here is a longitudinal muscle is there between the internal anal sphincter and then external anal sphincter. Here is the longitudinal muscle. This longitudinal muscle is nothing but the extension of the outer longitudinal muscle coat of the rectum, which gets continued down as the longitudinal muscle of the anal canal. Okay, so from this longitude muscle there will be multiple fibrous septae. You can see it is piercing the internal anal sphincter and external anal sphincter also. So a thick band of fibrous septa which come from the longitudinal muscle, which pierce the internal sphincter and pass through the submucosa and get attached at the dentate line. Okay, get attached to the dentate line. This is this structure gives actually structural support to the submucosa and mucosa of the anal canal. So it is a mucosal suspensory ligament. It is suspended from the mucosa, and it is attached, it is coming from the longitudinal muscle layer of the anal canal. Okay, that is mucosal suspensory ligament. So anal canal musculature, so it is for actually it consists of anorectal ring, internal anal sphincter, external anal sphincter. Okay, so anorectal ring, what is this? Is very important. Anorectal ring, because of this our continence is maintained. Okay, see, you can see this is the pubic symphysis, this is the rectum, this is the anus. So it is like a band like structure. It is a band like structure. Okay, band like structure or a sling like structure. It is formed by 4 components. One is puborectalis, external anal sphincter, internal anal sphincter, and conjoined longitudinal muscle. Okay, so puborectalis, you might have studied in the anatomy. Puborectalis is form a part of the pelvic diaphragm, and it helps in the important component of the continence mechanism. Okay, continence mechanism is while defecating it is controlling. So it is in this position only. In always humans in resting position, it will be creating an angle. Here you can creating an angle between the rectum and the anal canal. It forms a sling. So by this, the feces, whatever is collected in the rectum, it is not coming into the anal canal. Because of this sling, it is closing. And once their feces come and touch here, there are 5 nerve endings at the dentate line. So there will be a reflex and it will relax. So when it relax, then only the contents of the rectum will come into the anal canal. So inadvertently, while doing surgery, for example a fistulotomy or a sphincter saving surgery or do any procedure in relation to the anal canal, when you cut these sling fibers, there will be patient will have incontinence, will have fecal incontinence. So this is a very major part, puborectalis. Okay, and it is a component of levator ani. Next is the external anal sphincter. Here you can see the external anal sphincter. Actually it is a single muscle. Actually it is a single muscle, but it is divided by this longitude muscle into septa. Okay, septa, so that it is divided into 3 parts. That is the this is the deep part, superficial part, and the subcutaneous part. Okay, deep, superficial, and the subcutaneous part. So this is joining with the levator ani. It is continuous with the levator ani fibers. Okay, next it covers the entire anal canal. It covers the entire anal canal. It is a striated muscle and it is under our control. It is under our voluntary control. Okay, it is voluntary control because it is responsible to control our toilet action, because whenever you are in a public places, whenever you feel like defecating, you are able to control the defecation process. This is due to the external anal sphincter. So external anal sphincter is also a very important component for a continence mechanism, and this is supplied by the inferior rectal branch of the pudendal nerve, and it is red in color. Okay, and very important is inferior rectal branch of pudendal nerve is also supplying the sphincter urethra. Is also supplying the sphincter urethra. So that's why when this nerve is stimulated, there will be a feeling of passing the urine, and there is a feeling of passing of motion also. Okay. So conjoined longitudinal muscle means nothing but the longitudinal muscle which is coming from the rectum, outer muscle cord, will be joining with the puborectalis fibers, deep part of the puborectalis fibers, and it forms the conjoined longitudinal muscle. Okay, this conjoined longitudinal muscle will send, as I have told you, it will send multiple fibrous septa into through the which pierce through the external anal sphincter and the internal anal sphincter. Here it will form the mucosal suspensory ligament. When it comes down, it will form 9 to 10 or 10 to 11 yellow elastic fibers which pierce the subcutaneous part of the external anal sphincter here. Okay, and these get attached to the skin, corium of the skin. So these fibers are said to be called as corrugator cutis ani of Ellis. Corrugator cutis ani of Ellis. Okay, and the main action of this longitudinal muscle is when it contracts, it causes widening of the anal canal, shortening of the anal canal, and flattening of the anal cushions, and it averts the anal margin. So it will is also an important component in defecation. So when a person defecates, there what happens, what mechanism is happening is there is a shortening of anal canal, widening of the anal canal, and aversion of the anal margin. So then the patient, then the person will be able to defecate. That is due to the contraction of this conjoined longitudinal muscle. Okay. Next is the internal anal sphincter. Here I have shown you this internal anal sphincter. If you differentiate and study external and internal anal sphincter, it will be easy. See, external anal sphincter, it is a striated, whereas internal anal sphincter is non-striated. External anal sphincter is a voluntary muscle. It is an internal is an involuntary muscle. It is red in color external. Internal is pearly white in color, and external is a in continuation of fibers of levator rani, whereas internal anal sphincter, it is a continuation of the, this is the circular muscle coat of the rectum which continues down as the internal anal sphincter, and external sphincter is supplied by the inferior rectal branch of the pudendal nerve. Internal anal sphincter is supplied by autonomic supply. So there is an another term called non-adrenergic and non-cholinergic fibers. Okay, non-adrenergic and non-cholinergic fibers which also supply this internal anal sphincter. What is the importance of NA&C fibers is, so when these fibers get stimulated, or these fibers are situated in the internal anal sphincter. So when you cut an internal anal sphincter or when you dilate the internal anal sphincter, what happens? There will be release of nitric oxide. So when this muscle is stimulated, these nerves are stimulated and release nitric oxide. What is the action of nitric oxide? It causes relaxation. It causes relaxation. So whenever there is whenever in a case of fissure, for suppose in fissure we are doing anal dilatation. So in anal dilatation, what happens is these fibrous septa will be broken. Okay, these are pectin fibers will be broken. When these pectin fibers, there will be release of some nitric oxide and it causes relaxation. So relaxation, whenever there is relaxation, the patient will be able to defecate easily. The tone will be decreased. Okay, so this is the importance of NA&C fibers. So you will be knowing what is the blood supply. So blood supply of rectal, upper half and lower half. Upper half, it is supplied by, as I told you, superior rectal artery. In the same way, superior rectal vein, both will be draining into inferior rectal vein will be draining into inferior mesenteric vein. Okay, lower half, middle and the inferior, where the middle and the inferior will be draining into the internal iliac vein. Okay, that you will know. Okay, lymphatic drainage also, upper half it will be draining the posterior rectal group and the para-aortic group of lymph nodes, and the lower half of the anal canal, it will be first draining into the superficial inguinal, later followed by the deep inguinal. Okay. Next, nerve supply also above dentate line and below dentate. Above dentate line, it is supplied by autonomic nervous system. So it is very important. See, above dentate line, if you cut or if you put some cautery or diathermy, or if any foreign body is placed or cut or incised, anything you injure, there will be no pain. Okay, because it is supplied by autonomic nervous system. Whereas below dentate line, it is somatic spinal supply. Okay, spinal nerve is supplying the dentate line, inferior rectal branch. So patient when it is cauterized or when you give a cut, so fissure, in case of fissure, it is arising from the below dentate line to analward. So patient will have lot of pain. If there is cut above the dentate line, patient will not have any pain. So that is due to the nerve supply above the dentate and below the dentate line. Okay. Next important is the perianal spaces, ischiorectal space and supralevator space. Here you can see this is the perianal space. Okay. This is the ischiorectal space. This is the supralevator space. So what is perianal space? Perianal space constitute what? Here you can see blue color thing, external hemorrhoidal plexus, and this is the subcutaneous part of the external anal sphincter. Okay, below this septa, everything is the perianal space. Okay, so it is the most common site of abscess. It is the most common site of abscess formation. Next is the ischiorectal. Here you can see the ischiorectal abscess. So you may be given as a question. This is also a very important. Next topic I will be discussing about the anorectal abscesses. Why I have chosen this anorectal abscesses? That's why I'm telling you anatomy. If I tell you anatomy only, then only you will be able to understand. So this is the ischiorectal space. Here you can see this is the ischiorectal space. It is having an apex. See, this is the apex. It is joined by the levator ani and the obturator internus muscle and its fascia. Okay, this will form the apex. Whereas this is the base. So this base, here you can see a transverse fibrous septa coming from here, from the longitudinal muscle and reaching till the ischial tuberosity. So this is the transverse fibrous septa which forms the base of the ischiorectal fossa. This arises from the longitudinal muscle and it separates the internal sphincter from the subcutaneous part of the external anal sphincter. Okay, this is the base. So lateral wall is formed by the obturator internus muscle with the obturator fascia covering over it. Okay, here you can see a small canal, see a small pocket or small canal that is called as Alcock's canal. It is called as Alcock's canal or pudendal canal, which is situated just 1.5 inches above the ischial tuberosity. You can see 1.5 inches above the ischial tuberosity. You can see a canal within the obturator fascia that is called Alcock's canal or pudendal canal, which constitutes internal pudendal vessels, perineal nerve, and the pudendal nerve. Perineal nerve, pudendal nerve, and internal pudendal vessels. Okay, this is the outer wall, whereas the medial wall, inner wall, is formed by the levator ani muscle, the deep and superficial parts of the external anal sphincter. Okay, this is the relation boundaries. Okay, and anteriorly here you can see another diagram. Anteriorly, this ischiorectal fossa is bounded below by the gluteus maximus muscle, and here the white thing is the sacrotuberous ligament. Gluteus maximus and sacrotuberous is the posterior relation. Anteriorly there will be urogenital diaphragm. Okay, superficial perineal muscles and urogenital. So these are the anterior posterior relation. This is the lateral relation, medial wall, it has an apex, and the base. So this is also very important, ischiorectal abscess. Okay, so whenever any abscess has a abscess abscess will form within the ischiorectal space, it may trickle up into the supralevator space. It may trickle up into supralevator space, or from the supralevator space also the pus may come through. Here there is a hiatus. There is a hiatus, I have told you, apex. Here there is a hiatus or an opening, that is hiatus of Schwalbe, WALBE, Squalbe. It is called as hiatus of Squalbe. Through that hiatus or opening of Squalbe, so whenever any pus which gets accumulated in the supralevator space or in the ischiorectal space, the pus may go from ischiorectal to the supralevator or from supralevator to the ischiorectal through that opening. Okay. Now, this is a very important question. This may, this may be asked to you all. Okay, anatomical and surgical importance of a dentate line. Okay, what is dentate line is, dentate line forms the embryological watershed between the visceral structures above and the somatic structures below. And I have told you the nerve supply mucosa above the dentate line is supplied by autonomic nervous system, and below is inferior rectal branch of pudendal nerve. Next, venous drainage above is inferior mesenteric vein, so it will go joining with the splenic vein and form the portal circulation with the superior mesenteric vein. So whatever drainage is there, it will be going into the portal circulation. Below is the systemic circulation. That is below, it will be draining into internal iliac vein. So it will be going into systemic circulation. So lymphatic drainage is also very important. Above the dentate line, lymphatic drainage, I have told you, posterior rectal and para-aortic lymph nodes, and below that it is draining into superficial inguinal and deep inguinal lymph nodes. And internal hemorrhoids will be developing above this dentate line, whereas inferior hemorrhoidal plexus or external hemorrhoids will be developing below the dentate line in the perianal space. Okay. Next, anal glands open at this level into the anal sinuses. Okay, so anal gland infection, I will be discussing about this anal gland infection in the later topic. Okay. Next, rupture of the anal walls. So at this line only these are situated, anal glands are situated and anal valves are situated at this line, and due to hard feces, due to tearing of the anal walls, it results in a fissure in anal. And there are fine nerve endings are present at this line, dentate line. So when it is when the feces come and enter into this anal canal from the rectum, these fine nerve endings will be stimulated, and you will have a sense of feeling to defecate. Okay, sense of feeling to defecate. This is the voluntary control mechanism for the continence. Okay, it will you will be feeling of passing defecation, feel of defecating. Okay, feeling to defecate. This is due to the stimulation of the hard feces touching the nerve endings. Okay, so this is the anal canal anatomy. Now coming to anorectal abscess. So now I think you understood the surgical anal canal. What is the anatomy? What is the musculature? Now, if I tell this anorectal abscess and fistula in ano, if whatever I tell further topics regarding the anal disorders, then you will be able to understand, because of this anal canal anatomy I have discussed. Okay. So anorectal abscess, here also you can divide. Whenever a question is raised, you will be definitely asked anorectal abscess, fistula in ano, fissure in ano, hemorrhoids, and the other important is the carcinoma of the anal canal. So these are the important few 4 to 5 topics in relation to the anal canal, but these are very important. So from anatomy to the carcinoma till all the major and the most common disorders of the anal canal, they will be asking as questions, and you will be asked as anorectal anomalies also. Anorectal anomalies I will discuss later. That for that you need to understand the embryology. You need to understand the embryology of the anal canal. Okay. So today I will discuss this anorectal abscess and finish off. Okay. So if a question as anorectal abscess comes to you, then you should be able to write what are the spaces around the anal canal. I have discussed to you the spaces in the previous PowerPoint presentation. There are the 3 spaces I have discussed. That is the perianal, ischiorectal, supralevator. Because these are the major sites of abscess formation. But there are other 3 sites. There are other 3 sites where the abscess will be formed. Okay, 3 sites where the abscess will be formed. That I will discuss in this diagram. See here. Here you can see number one I discussed is supralevator space. Okay, here abscess can form. This is ischiorectal fossa or ischiorectal space. Here also abscess can form. This here you can see perianal space. Okay, perianal space. This is the perianal space. Here also abscess can form. And there is another space here near the very near to the anal canal margin here. Okay, that is the marginal space or mucocutaneous space. Okay, there also abscess can occur. When abscess occurs in the marginal space, it's called marginal abscess or mucocutaneous abscess. And abscess can occur in the submucous space. Here you can see submucous space, that is between the mucosa and the internal anal sphincter. Submucosa space. Okay, that submucous space also, when infection occurs, there will be a submucosal abscess. Okay, next there is an intersphincteric plane. Here intersphincteric plane is there between the internal and the anal sphincter and the where external anal sphincter. Here intersphincteric plane, that is an intersphincteric space. There also abscess can occur, that I will tell you later. So these are the 6 sites. These are the 6 sites where abscess will form. Okay, among these 6 sites, the most important 3 sites are the supralevator, ischiorectal and perianal. Okay, mostly our patients will be coming to our surgical or OPD with these abscess in the following what sites I have discussed. Okay. So next, what is the etiology? So how this anorectal abscess will form? So there are 2 theories. Sorry, these are the spaces I have discussed. I have told you: supralevator, ischiorectal, perianal, marginal, submucous, and so next, etiology. So etiology you can divide into 2. Okay, one is the cryptoglandular and non-cryptoglandular. Cryptoglandular theory, which is defined by Parks. Dr. Parks has defined this cryptoglandular theory. Okay, cryptoglandular theory is nothing but, so I have discussed you in the previous slides. Crypts, at the crypts, anal crypts, there are at the level of anal, at the level of dentate line, there are anal glands. There are anal glands which are situated in the intersphincteric plane. Through this intersphincteric plane, from this intersphincteric plane, anal glands have anal ducts. These anal ducts will be opening into the anal sinuses at the level of the dentate line in the crypts. Okay, so this is cryptoglandular theory. So what happens is, whenever there is an infection of the anal gland, so these anal glands situated in the intersphincteric plane, whenever they get infected, they form infection and they form abscess. So what happens, that abscess, pus will be formed. That pus, where it will go? So the pus in the intersphincteric plane here will go where there is least resistance. Least resistance means it will go into the dependent part. That is, it will trickle down. It will trickle down and it will get connected through the septa. They will come through along the septa and get accumulated in the perianal space. So and form perianal abscess. Okay, it forms perianal abscess. And another thing is, these pus can, through this transverse septa, you can see here, through this septa, the pus can trickle from the intersphincteric space to the ischiorectal space, into the ischiorectal space. Okay, and another spread is from the intersphincteric space, anal gland infection, pus may trickle upwards into the supralevator space. So these are the most commonest sites where when there is an intersphincteric anal gland infection. Okay, so here I have written, there is a course of spread is perianal, ischiorectal and supralevator. So this pus may be present on one side, or it may be present bilaterally, or it can be present circumferentially also. It can be present circumferentially. So a point of importance here is, here ischiorectal abscess. See, ischiorectal abscess will be, when it is formed, it can go behind. It can go behind this. See, I have told you anococcygeal ligament. So it will go behind the anococcygeal ligament and it can go into the opposite ischiorectal fossa. So then it will form a horseshoe shaped abscess. It will form a horseshoe shaped abscess or a horseshoe shaped fistula also. Okay. So this is the cryptoglandular theory. So what is non-cryptoglandular theory? So other than the anal gland infection, there are some specific causes. Non-cryptoglandular theory, or it is also called specific causes. Specific causes for causing anorectal abscesses. Okay. So the infection can occur at the same sites where I have told you supralevator or perianal or ischiorectal, and it can occur at the other sites also. What I have discussed, submucous space. So example for that is following an injection sclerotherapy for a grade 1 hemorrhoids. If the patient comes with a bleeding per rectal and you have diagnosed as grade 1 hemorrhoids or early second degree hemorrhoids and you have planned to give injection sclerotherapy. So when you give injection sclerotherapy above the dentate line and if you give into the submucous space and if you have not taken proper precautions, proper sterilization methods, aseptic precautions you have not taken and you have injected, so it may cause a abscess over there in the submucous space. Okay, that is a one cause, and another is the marginal space or mucocutaneous space. Whenever, see, I have told you here there are external hemorrhoidal plexus or inferior hemorrhoidal plexus. So if any plexus or here veins will be there, if the vein gets ruptured, there will be accumulation of accumulation of blood followed by a clot formation. That infected hematoma may get infected and form an abscess. So it occurs at the margin or the mucocutaneous junction. It is called as marginal abscess. Okay, next is the ischiorectal. So there are some causes. So a foreign body or a trauma to the ischiorectal space. So for example, if you see, if the patient fall from a while riding a bicycle, and if he falls from the bicycle and fall on the road, and if he has an injury to the ischiorectal region, some stone or some nail gets inserted into the ischiorectal region, that may cause the ischiorectal abscesses. Okay, next is supralevator. So apart from this intersphincteric anal gland infection, there are some diseases, there are some specific diseases, that is neoplasm of the rectum, Crohn's disease, and pelvic disease. Pelvic diseases, there could be some gynecological disease, that is pelvic inflammatory disease, or some appendicular, from appendicular inflammation or an appendicular abscess. So that in such cases, what happens, that pus will be trickling down into the supralevator space. So these are all pelvic components. So anything in the pelvic area, if the organs has any infection or inflammation, if there is an abscess formation, that pus may be trickle down into the supralevator space. Okay, that might be another cause. Okay, and the other causes, general causes, are the diabetes and acute immunodeficiency syndrome, AIDS. Okay, these also causes a formation of abscesses in the spaces mentioned. Okay, next, what are the clinical features? So a patient presents with a perianal abscess. Perianal abscess, usually it is a short duration. See here, you can see in diagram. Here you can see in diagram. Here from the longitudinal muscle, there are multiple fibrous septa are coming. Multiple fibrous septa which are piercing the subcutaneous part of the external sphincter, and it is attaching to the skin. Okay, here there will be lot of tissue tension will be there. There will be a lot of tissue tension will be there. So any abscess which get collected here, it is unable to actually what has there is no other way to burst out. So what happens, there will be stretching of the skin here, there will be stretching of the skin, and stretching of there will be stimulation of the nerve endings, and patient will have lot of pain, because If abscess gets accumulated, pus accumulates here, there is no other way to go. It has to come out of the skin. So the skin will be stretched. So the patient will have immediately come to the surgeon for checkup. So he will be presented with a presenting with a pain, acute pain of short duration, which is throbbing type of pain, and with a swelling near the perianal region, and the patient will have a mild fever also. Okay, on examination you can see a swelling will be situated in the perianal. You can, if you touch, there will be local warmth will be there, and the swelling will be tender, and there will be redness will be there, and there is induration, and there will be a pus fluctuating point will be there at the top of the abscess. Okay, there will be softness in the center of the abscess. Okay, that indicates that that is the stretching of the skin and it is about to burst. Okay, that is fluctuation will be there, positive will be there. Okay, that is the perianal abscess. Next is the ischio, whereas in ischiorectal abscess, see here you can differentiate. See here in ischiorectal abscess there is lot of space is there. Okay, so the pus can move nicely. Okay, it has no tension, it is very deep, it has a lot of fat is there, and it has no tissue tension. So the pus will accumulate and form a big abscess that the patient will not appreciate. Patient will not have that much pain as when compared to the perianal, because here the tissue tension is more, whereas here the tissue tension is less. So here pain will be more perianal, whereas ischiorectal pain will be less. But due to deep seated abscess, patient will have high fever. Patient will have high fever. Okay, patient will have high fever than pain. Okay, on examination if you see, there will be no well localized swelling. You can visualize there will be a diffuse swelling, there will be a diffuse swelling, and there will be diffuse tenderness, deep tenderness will be there, and induration. Okay, induration will be there. Whereas in supralevator you can see, you will see nothing. Patient will also have nothing, but patient will have some deep rectal pain, because supralevator space is above the anorectal junction. This is the anorectal junction. So above the anorectal junction is the supralevator space. So patient will be having some deep rectal pain which is unexplainable. Okay, which cannot be appreciated by the clinician also, because it cannot be visualized. Patient will have deep seated abscess, patient will have also fever, and patient will have some micturition disturbances, because it will be irritating the urogenital system, because urogenital system will be near to the rectum. So it will be irritating the urogenital system, and patient will be having a feeling of passing urine frequently. Okay, that is due to irritation. Okay, so the main complaints of the supralevator abscess is patient will come off deep rectal pain, fever, some micturition disturbances. So on examination, if you make the patient to lie down on the table, you can't see anything, nothing you will not see on external appearance. Only perianal abscess you can see, or ischiorectal abscess, some to some extent you can see some diffuse swelling or a induration. But supralevator abscess, nothing you can't see, but you can appreciate on perrectal examination. So if you put a finger and you go above anorectal junction, that is above 4 centimeter, and if you palpate, you will be feeling some bogginess. You can feel some bogginess of the swelling. Supralevator palpation, on palpation you will feel some supralevator swelling or supralevator induration. Okay, and if you press it hardly, it will patient will have pain, that is tenderness will be there above the anorectal junction. That will suggest there is a some supralevator abscess. So this is very important to differentiate when the patient present with some pain and patient complaints of a fever. You should be putting the you should be doing the digital rectal examination, per rectal examination, and you can feel the swelling. Okay, if you feel that swelling, you will never forget in your life. Okay, that will be clinically evident. So next is the management. So how do you manage? So for any abscess, the drainage anywhere in the body abscess drainage is the surgery is the treatment. So when you post the patient for the surgery, you give spinal anesthesia in lithotomy position. You will examine and examine the anal canal and the perianal region under anesthesia. If required, you can do a proctoscopy or a sigmoidoscopy also. Okay. So whereas in perianal abscess and ischiorectal abscess, those all tests are not needed. Just on external examination, you can be able to appreciate. You can able to appreciate this perianal and ischiorectal abscess. So what you do is a cruciate incision. What is cruciate incision is give a plus shaped incision. You give longitudinal incision and a transverse incision. You give a plus mark incision. So once you give a plus mark incision, there will be 4 flaps in the 4 quadrants. You will have 4 flaps. Those flaps should be cut. So that is called de-roofing of the skin flaps. When you de-roof the skin flaps, there will be a wound will be there. Wound occurs. Now you will put a sinus forceps. You will put a sinus forceps into the wound and you open the sinus forceps. And with the open sinus forceps, you bring out the sinus forceps out. So what happens when you open that? You have opened the abscess cavity. So when this abscess cavity is open, the pus will be drained out. So the pus which has been drained out is sent for culture and sensitivity. And you will be taking some tissue from the abscess wall, tissue for histopathological examination. Okay. Next, and the necrotic tissue will also be there over the walls of the abscess cavity. That necrotic tissue you should not pull with a forceps. Instead of that, you will take a gauge piece and the gauge piece is rolled over your finger, gloved finger, and you will scratch the necrotic tissue with the gauge piece. Okay. So why with not with the forceps is when you pluck the necrotic tissue with some artery or a forceps, there may be an underlying vessel which you don't know. That maybe that slough is covering the underlying vessel. If you catch hold of that vessel and if you pluck, means what happens? There will be torrential bleeding. So instead of that, you just scrape it off. You just scrape it with your gauge piece. Okay. Next, that pus you have sent for culture and sensitivity and tissue for histopathological examination. After that, what you do is you will give a thorough wash with hydrogen peroxide and saline. Hydrogen peroxide and saline wash you give, and you take gauze pieces and you soak it in betadine, squeeze it and place into the wound cavity and do a dressing. Apply a T bandage, apply a dressing, well padded dressing. Okay. So if during this procedure you should be looking for the fistula. There may be an associated fistula also. So if there is a fistula, then you can apply a sit-on. You can apply a sit-on. That I will later I will discuss about this fistula in my next class. Other disorders. So you will be applying a loose sit-on, or in rare cases you will do fistulotomy. Okay, that you will do. And this, when the pus is pus for culture and sensitive, the report comes if it contains the skin organisms. If it contains the skin organisms, then it indicates that it is not a fistula. Okay. In the abscess cavity, if the pus is sent for culture and sensitivity, and if it comes as staphylococcus or streptococcus, then you can say, you can tell that there will be no underlying fistula. But if that pus constitute of gut flora like Escherichia coli, if the gut flora is present, then you should be suspecting that there should be an underlying fistula. Why? Because see, any skin infection. So abscess can occur from a boil also, from a folliculitis. See, around the perianal region, there is a lot of hair will be there. There will be a folliculitis also, or a simple boil also. That infection may spread downwards and it forms an abscess also. So in such abscess, if you take a pus culture and sensitive and if you find out staph aureus, that is no need to worry that there will be no fistula. But if in the pus, if you find out an Escherichia coli organism, then it indicates that this abscess is formed from the connecting route is from the anal canal or the rectum. The pus has come and came out. So underlying any fistula is there or not, we can tell by this pus culture and sensitivity report also. Okay. So this is supralevator abscess. Supralevator abscess, one, there are actually two types of drainage. See here in supralevator abscess, what happens? See, I have told you intersphincteric plane, there is anal canal, anal gland infection. Their abscess may spread. The abscess may spread either in the supralevator space, either in the supralevator space into the pelvirectal space here, like that it will can go outwards, or it can settle here. Abscess may get settled here in this region. Okay, so there are two types of drainage. If the abscess is localized here, then if you put a finger and feel a boggy swelling here with your finger, if you can palpate the swelling, if you appreciate that swelling parectally, then you take a wide bore needle under guidance, under half anoscope proctoscope you put, and under guidance you put a wide bore needle and puncture it, and puncture this abscess. So whatever abscess which is well localized will come out through the opening which is made by the wide bore needle, and it will drain intrarectally and come out. Okay, when this abscess is very much laterally, supralevatorly, that abscess which cannot be drained so easily, in such cases you have to give a skin incision in as that of ischiorectal abscess, and you need to cut this, you need to pierce it, make a rent, and you need to drain the abscess. Okay, this is how a supralevator abscess is drained, either intrarectally or by skin incision. So this is the anorectal abscess. In the following later classes I will be discussing about the other anorectal diseases also. Okay, so I hope you understood this class. Okay, so thank you.